Hello, everyone, and welcome. Thank you for joining us today for our program on the Meaningful Use Stage 2 and Standards and Certification Criteria Final Rules. This is Kate Berry, CEO of National eHealth Collaborative. National eHealth Collaborative is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care. We work very closely with the Office of the National Coordinator and focus on three major programs: health information exchange, consumer engagement in eHealth, and health IT education. Today we are very pleased to welcome Dr. Farzad Mostashari to make opening remarks, and then we will have Rob Anthony from CMS and Steve Posnack from ONC to discuss these two very important final rules. In just a few moments, I'll introduce our speakers. Next slide, please. First, I'd like to provide a very brief overview of NeHC's membership program and just a few of our upcoming education programs. We just recently launched a membership program, and the benefits are highlighted on this slide. They include visibility and recognition for being part of an influential health IT organization, preferential participation in leading strategic work groups, unique networking opportunities with industry leaders, and weekly summaries of health IT media stories and synthesis of critical information. For more information, please visit our website. Next slide, please. This slide highlights our current members, and we are pleased that diverse and leading organizations have joined, including health systems, patient-focused organizations, health information exchanges, public health departments, state agencies, technology companies, quality-focused groups, and many more. We're grateful for our members' leadership and support of NeHC, and we encourage all of you who are interested to consider joining. Next slide, please. Given the significant information in these final rules, we are going to both make a recording of this session available later on this afternoon, and we're going to repeat this program twice next week. First on Tuesday, August 28th, and then again on August 30th. And on both of those days, this will be from noon to 1:30 Eastern Time. And you can register at the URL on the screen or at www.nationalehealth.org/finalrules. An option to call in will also be provided in case we once again exceed the capacity for people to join via the web. On September 5th, coming up right after Labor Day at 2:30, we'll have Gwen Darlinger presenting Health IT Orientation, which will provide an overview of healthcare industry landscape and trends, including both government and private sector initiatives. And then on September 11th at 1 o'clock Eastern, we'll be kicking off a new series on health IT in rural and underserved communities with the rural health IT landscape. Our speakers for this program will be Earl Rugg from the Rural Health IT Corporation and Chantal Warzawa with the American Hospital Association. Next slide, please. Once again, I just want to make you aware that the slides from today's program are available at nationalehealth.org/finalrules, so you can access the slides there. And next slide, please. So during the program today, please do enter your questions as they come to mind. You just need to type them into the Q&A window at the bottom right-hand side of the screen. And now I'm very pleased again to introduce our speakers for today. So first up, we'll have Dr. Farzad Mostashari with opening remarks. And Farzad is the 4th National Coordinator for Health IT. He's widely known for his career and many extraordinary accomplishments in public health and informatics, not the least of which was as lead investigator in the outbreak of West Nile virus and anthrax in New York City. Farzad graduated from Yale Medical School and the Harvard School of Public Health. Then we'll have Rob Anthony, who's a health insurance specialist in the Office of eHealth Standards and Services at the Centers for Medicare and Medicaid Services. He works primarily on meaningful use policy for the Medicare and Medicaid EHR incentive programs. And Steve Posnack is the Director of the Federal Policy Division within ONC's Office of Policy and Planning. He's been with ONC since July of 2005, and Steve has served as Project Officer of the Health Information Security and Privacy Collaboration and also as a lead staff to the American Health Information Community Confidentiality, Privacy, and Security Workgroup. Steve is now responsible for ONC's legislative and regulatory affairs. So now I would like to turn the program over to Farzad for his opening remarks.
Thank you so much, Kate. I wanted to just make note of a couple of things before we turn it over to the experts. The first overall message, I think, is that I think while it may not be great for journalism, it is good for policy making that the final rule is largely predictable. Predictable based on the discussions in the Notice of Proposed Rulemaking, the feedback from the Health IT Policy and Standards Committees, and the comments we've received. And I think that degree of predictability is going to help in terms of us, as they say, showing our work, how we arrived at the decisions we did and why. In this, I think what you'll see is some compromises, frankly, between the aspirational goals and the realities of where the market is and the pressures on providers and vendors in terms of timelines. It doesn't mean that we don't have our eye on the prize. It doesn't mean that we're not making progress and stepping up, but it does mean that we have to keep our feet on the ground, as our principles go. The other main message here is that this represents, I think, while people can compare, particularly inside baseball, to the Notice of Proposed Rulemaking, if we just compare what's in Stage 2 to what was in Stage 1, what we could do in Stage 1, again, not for lack of ambition, not for faint expectations, but what we could do in Stage 1 2 years ago compared to what we can do in Stage 2, certification criteria, standards, and meaningful use in 2012, we've made an enormous amount of progress as a country. And a lot of the issues that we faced then, we don't face anymore. So that's all tremendously positive for us as a country. And much of it is due to the really relentless and hard work of not just our teams, but of over 1,000 volunteers who engaged in accelerating industry consensus. And the end result of that is that we can do a big push on standards-based care coordination and exchange by 2014. The country is going to be in a qualitatively different place, I believe, in 2014 when it comes to the ability to exchange information between providers and public health, and very importantly, between providers and patients and their caregivers in 2014 than when we are today. And the switchover is going to begin in 2013 when the systems begin to be certified and rolled out across the country. What are these advances in interoperability and exchange? I think it's really in 4 domains. The first is what we could set as standards and perhaps more importantly implementation specifications and vocabularies. That's part 1. 2 is the certification program. 3 is what meaningful use requires. And 4 will be other policies and the context, policy context within which information exchange takes place. So let me talk a little bit about each of those 4 and why I believe that the same hockey stick curve that we've seen for increased adoption of electronic health records, we shall see the same hockey stick trends when it comes to the availability of information when and where it's needed for patient care. First, on standards. We've defined, and you'll see in the slides that are going to be presented, we've defined a common meaningful use data set that's defined for all summary of care records, transitions, discharges, patient access, that really includes an impressive array of data elements. And increasingly, those data elements are associated with standardized formats and vocabularies and contents. The name, the referring or transitioning provider's name and office contact info, procedures, encounter diagnoses, immunizations, lab test results, vital signs, height, weight, blood pressure. smoking status, functional status, demographic information like preferred language, sex, race, ethnicity, date of birth, care plan field, goals and instructions, care team, including the primary care provider, discharge instructions for hospitals, and reason for referrals. This is huge. It isn't everything, but it's huge. If you think about the advances that groups have made in exchanging just the ADT information and what we can do with that, combine that now with all of the other data fields that I just talked about, combine that with standardized coding of those fields, and you really start to add up to something that's not just evolutionary, but revolutionary in terms of our capabilities. And that's just one. If you think about the other implementation guides and specifications for laboratory results delivery, where we just didn't have that sort of consensus a couple of years ago, and we accelerated through the community and resolved those differences, balloted those differences, and now we can provide implementation guides for a single standard. There's so many other implementation guides here around cancer registries and immunization reporting and public health reporting. So all of these taken together are working to increase the level of specificity, decrease the cost and optionality, and with transport. So make sure that we can use the internet to securely exchange health information without having to negotiate each and every transaction, including push as well as query using the SOAP-based optional standards. But we went beyond that. It's not just standards and certification criteria for how the information should be formatted. It's also what the system does in terms of helping get into the workflows of actually importing that data into another system, to be able to have backward compatibility with CCR and CCD and continue to receive those during the transition phase, where some providers are going to be on 2011 and others on 2014 edition software. But to be able to do identity reconciliation when a document comes in and to match to the right person, to be able to do the incorporation of medications and med list and problem list by doing that reconciliation process, to have labs come in and populate the record, but to have all the other elements, not only the ones that are reconciled, but all the other elements be available tagged with their metadata and be able to be pulled up in segments, not just as a document as a whole. So getting to that vision of atomic data with metadata attached to it. That's just what we've done on the standards and implementation guides. And I think Doug Fritzma and the S&I team deserve an incredible amount of credit for, and as well the community who's engaged with these projects for getting us to this point. But two, we describe that we are you have yet to see the test scripts, but trust me, it's going to be good in terms of having much more rigorous testing in our certification program. So being quite explicit, for example, around the data elements needed for quality measures, something that was a major pain point. Moving testing for interoperability towards where we can actually have functional tests of interoperability, a catch and throw from a sample EHR rather than just looking for conformance through schematrons, and using scenarios to thread together different certification criteria. We're going to need your help on getting this right. We're going to be over the next few months releasing in waves the certification test scripts and criteria, and perhaps just as important as the comments were on the NPRM is going to be comments and improvements and suggestions and your engagement on getting the certification testing right, and I'm confident we will. And now we move to meaningful use. If standards and certification talk about what the capabilities of electronic health records are, in this case for information exchange and interoperability, meaningful use gets at the behaviors of providers and hospitals. So including hospital labs as a menu item for outpatient lab results delivery, I think will go a long way towards making sure that that outpatient providers have access to structured, codified laboratory information. The public health reporting moving from tests of exchange to actual ongoing exchange, except we're prohibited by law. Being able to have the patient actually download and access and view and transmit to third parties their own information in human readable as well as in machine readable formats. And the work we're doing with Auto Blue Button will, I think, be truly revolutionary in terms of making it much, much easier for patients not only to download it once, but to set it and forget it. And when it comes to cross-vendor, we recognized in the rule, and we discussed at length, that the goal here is that information follows the patient regardless of geographic, organizational, or vendor boundaries. And in the notice of proposed rulemaking, we proposed that 10% of all transitions be accompanied with an electronic copy across vendor boundaries. And that, as was pointed out in nearly every comment, as well as the Health IT Policy and Standards Committee, that is difficult, not because we don't believe in the principle, not because it's not the right thing to do, but because of the measurement burden and challenge of even identifying what is an exchange across vendor boundaries. So we kept the 10% threshold, that 10% of all transitions of care need to be accompanied with an electronic summary of care with all those data elements in structured format. But we said we can't measure it, but it has to exist. There has to be at least one that goes across vendor boundaries or with a CMS-designated test server, as you'll hear. And what we said was that we made it clear that walled gardens go counter to our policy intent. I'm gonna read from the segment from the final rule. We continue to believe that making vendor-to-vendor standards-based exchange attainable for all meaningful EHR users is of paramount importance. In that regard, and as we look toward meaningful use stage 3, we will monitor the ease with which EPs, eligible hospitals, and critical access hospitals engage in electronic exchange, especially across different vendor EHRs. If we do not see sufficient progress, or that continued impediments exist such that our policy goals for standards-based exchange are not being met, we will revisit these more specific measurement limitations and consider other policies to strengthen the interoperability requirements included in meaningful use, as well as consider other policies and regulations through which the department could effect the outcome we seek. I want there to be no question about the seriousness of our intent on this issue. Bottom line is, it's what's right for the patient, and it's what we have to do as a country to get to better health care, and lower cost. That's what meaningful use is all about, and I believe that as we move further our experience with stage 1 and begin to move towards stage 2, each on our own personal escalator, the country will make increasingly meaningful use of this roadmap, really, for how to deliver care that's higher quality, more efficient, safer, more coordinated, and more patient-centered and secure. With that, I turn you over to our dear friends and colleagues at CMS.
Thank you, Farzad. Thank you to everybody who has shown up today this afternoon, and thank you to NEHC for sponsoring this webinar. My name is Rob Anthony. I'm with the Office of eHealth Standards and Services in the Centers for Medicare and Medicaid Services. We are the office within CMS that coordinates the EHR incentive programs. I'm going to give you a, believe it or not, a quick overview of what is in the Stage 2 final rule, even though after all of these slides you may not feel that it was necessarily quick. There is a lot of information in here. And then I'm going to turn it over to Steve Posnack from ONC, who is going to give us an overview of what the companion ONC rule on standards and certification holds for us. So we're doing this a little bit low-tech because, unfortunately, I do not at the moment have internet access, so I'll be indicating next slide. And right now we can go to slide number 2, what is in the rule. Although we call this the Stage 2 final rule, there are actually a number of things in this that are not necessarily specific to Stage 2. There is, of course, the criteria for Stage 2 of meaningful use, the core and menu objectives that people will have to meet. But there is a new specification for clinical quality measures that everyone will begin reporting in 2014 in order to coincide with the new 2014 certification standards. There is a detail about the payment adjustments and hardship exceptions that were provided for. There are some changes to the Medicaid program, specifically to patient volume calculations that will go into effect in 2013. They are not necessarily, again, limited to stage 2. And then finally, that first bullet on the top, there are actually some changes to stage 1 that are included in this rule as well. And we're going to go over all of those things briefly in this discussion. So next slide. Farzad did a much better job than I probably could talking about what stage 2 means for all of us. So just very quickly, I will say that while a lot of what you will see here is familiar from stage 1, we retained most of the objectives as we had indicated that we would in the notice of proposed rulemaking. There are some new criteria that we have included for stage 2, both in the core and in the menu sets for people. Obviously, there's some new criteria for reporting clinical quality measures as well. And as Farzad eloquently pointed out, all of this aiming towards the notion of improving patient care, reducing healthcare costs, and saving patient lives. Next slide. So I want to talk very briefly about eligibility because this is one of the first things that comes up in discussions of the program. It is something that we got a number of comments about during the comment period for the stage 2 notice of proposed rulemaking. And we did want to specifically address some of the questions about eligibility. If we go to the next slide, slide 5, we had a number of comments where people asked, could you open this up to this type of professional? Could you open this up to long-term care facilities, so on and so forth? The important thing to know here is that eligibility for the program was actually determined by law. Congress, within the HITECH Act, and as part of our specified what hospitals would be eligible, specified which healthcare professionals would be eligible to participate. And there haven't been any changes in the HITECH Act, so CMS is not actually able to change anything with eligibility except specifically those things that were within our regulatory purview. And slide 6, the next slide, will show you one of the areas where we did institute a change because we were able to look at the hospital-based EP definition. We had heard from a number of EPs who are currently deemed to be hospital-based that they may work within a particular area or unit of the hospital, and their charges may technically put them in that more than 90% of their covered professional services within an inpatient or emergency department, but some of them are special cases in which they are actually using their own separate EHR. It is separate completely from the hospitals, and they would be able to meet meaningful use using that technology. So we did introduce a change here for hospital-based, where if EPs can demonstrate that they fund acquisition, implementation, and maintenance of their own certified EHR technology, including supporting hardware and interfaces needed for meaningful use, and they're not receiving assistance for this from an eligible hospital or a CA, and they're using this instead of using a hospital's certified EHR technology, they could be determined to be non-hospital based and potentially receive an incentive payment. That determination is going to be made through an application process. As you'll see for a couple of things here, there are application processes for them, including hardship exceptions. We have not posted information about that because the rule's been out for 24 hours. But we will have information on that posted on our website when we have that process open. Next slide. So now I want to do a rundown of specific things about Stage 2 meaningful use. These are criteria specifically for meeting meaningful use in Stage 2. And if we go to the next slide, the first thing that we want to talk about, and I think the first thing that everybody wants to talk about, is the delay in Stage 2. A lot of people, we had heard very early on that there were going to be some hurdles to people who had first adopted in 2011 being able to meet meaningful use Stage 2 beginning in 2013. We had taken a lot of that to heart, and in fact, the Secretary of Health and Human Services had indicated that we would institute a delay of a year for Stage 2 for those providers, announced that, and we announced the same in the NPRM. We are maintaining that delay. So this neatly illustrates what your meaningful use path would be as a Medicare EP If you had begun in 2011, you will essentially get another year in 2013 at Stage 1 requirements before having to move in 2014 to the Stage 2 requirements. Obviously, on the Medicaid side, these don't have to happen consecutively, so it is possible that you could have begun your Medicaid in 2011 and not come back until some later years. But everybody is going to begin. We've made this in a number of the Stage 2 NPRM presentations, but everybody begins at Stage 1. You will do 2 years at Stage 1, and then you progress to Stage 2. The only exception for that is in 2000. If you began in 2011, you're going to get that extra year at Stage 1 in 2013. Next slide. Slide 9, this holds true for hospitals as well. Obviously, EPs work on a calendar year. Hospitals work on a fiscal year, but you would do it the same way, where you would do 2 years at Stage 1 and then follow into Stage 2 and then follow into Stage 3. So if you started as a hospital for meaningful use in 2011, you will get an extra year at Stage 1 requirements in 2013. The other thing that we have introduced here for both EPs and hospitals is that in 2014, we have provided flexibility for implementing during that period, because there are going to be a number of providers, a very large number of providers, who will all be upgrading to their 2014 certified technology all at the same time. We were concerned about a funnel effect with a number of people coming in and not being able to onboard quickly enough. So instead of requiring for people to demonstrate a full year of meaningful use in 2014, providers may demonstrate a 3-month reporting period. There will be 3 months that are tied to the quarter for Medicare providers, people who are attesting to CMS, and we align that to the quarter in order to align with some of our other clinical quality measure reporting programs. But we believe that this basically gives some extra flexibility as to when you implement in the 2014 year. This will be true regardless of your stage of participation, whether you are Stage 1 or Stage 2, because everyone will be upgrading to 2014 technology, even if they are participating in Stage 1. So there is some added flexibility beyond just that extra year for people who started in 2011. There's going to be that flexibility in 2014. If you are on the Medicaid side, incidentally, it will also be a 3-month period, but it will, or a 90-day period rather, but it's not necessarily tied to the quarter. We're only tied to the quarter with a 3-month period on Medicare because of aligning with those quality programs. Next slide. So this is a really high-level overview of what meaningful use looks like as we transition from Stage 1 to Stage 2. On the left is Stage 1 for both eligible professionals and eligible hospitals. That is our 15 core objectives, 5 of 10 menu objectives for a total of 20 objectives. You'll see that we kept the total number of objectives relatively the same, as we indicated that we would in the Notice of Proposed Rulemaking. There are now 17 core objectives for eligible professionals, a total of 6 menu objectives, of which EPs have to select 3. On the hospital side, it's 16 core and 3 of 6 menu objectives. We accomplished staying at the same number primarily by either, in some cases, eliminating a couple of objectives that were no longer necessary because of some Stage 2 objectives, or some 2014 EHR functionality. In other cases, we actually combined some objectives together because the measures were very similar. So, for example, the clinical decision support measure and the measure to implement drug-drug and drug allergy interaction checks are all part of a clinical decision intervention objective now. There are other things like the recording of problem list, recording of medication list, and recording of medication allergy list, which have been combined with some other objectives. Essentially, they are not required to be recorded on their own, but in order to meet certain objectives like transitions of care, providing a summary of care, you have to have information on problem list, med list, and medication allergy list, so you would still need to maintain those. We did take a look at not only the comments that we got from people during the public comment period, but we took a look at the data that we have about stage 1 meaningful use, and all of the data that we have now indicates that for those recording objectives, the compliance was incredibly high. So we felt that we were on very safe ground, and including those as a requirement as part of other measures. Slide 11, next slide. Overall, some other basic changes and some things that we want to make sure that people are aware have not changed, but on the left-hand side, you'll see one of the changes is a change to how the menu objective exclusions worked. In stage 1 previously, you were able to select a menu objective and then exclude out of it if you met that particular exclusion. Starting in 2014, and certainly for as we move into stage 2, you will not be able to do that. If you are able to meet a menu objective, if you are able to meet menu objectives, you cannot select other menu objectives and exclude from them. And if you select a menu objective and exclude from it during attestation, you are also attesting that you can exclude from all of the other menu objectives. That won't prevent you from meeting meaningful use if you are able to be excluded from more than the required number of menu objectives, more than the 3 of 6 that you have to report on, but it does prevent people from selecting a menu objective and excluding from it. There are others on which they can report. What hasn't changed in meaningful use is over on the right-hand side. We still have that 50% threshold for EPs who work in multiple locations that are equipped with or without certified EHR technology. You have a 50% threshold that 50% of your outpatient encounters have to occur at locations that have certified EHR technology. What hasn't changed here is that meeting the objective is meeting the measure of the objective. In other words, meeting the e-prescribing objective means surpassing that threshold. That is the requirement. That was the requirement in stage 1, and nothing has changed for stage 2. Nor has it changed that the denominators are based on your locations with certified EHR technology. So if you meet that threshold, you are able to limit your calculation of your denominators to just those locations that have certified EHR technology. We do often get asked if you can limit it to just one location if that one location has more than 50%, but it does mean that you have to include all locations with certified EHR technology. Next slide. So the 2000 changes, we've sort of talked about these as we've gone through it. Obviously, starting in 2014, everybody who is participating in the programs are going to have to adopt the certified EHR technology that meets those 2014 certification criteria. Because of that, we have that reporting period where we reduced it to 3 months in 2014 only. And this is, again, for all participants. It is not just for people in stage 2. It is for everybody, because everybody in 2014 will be trying to onboard with that technology at the same time. Next slide. One of the things that you will discover in the stage 2 final rule is a discussion of batch reporting. We did propose this in our stage 2 NPRM, and we are adopting it. Beginning in 2014, groups will be allowed to submit attestation information for all of their EPs in a file upload, rather than going through, as you would have to do now, for each individual EP and entering numerator, denominator, and so on. If you have this is especially useful and will definitely reduce burden for large practices with 100, 200 eligible professionals. We will specify what the file format is and how everything has to be entered, and then you'll be able to submit that and upload for everybody. You're still going to have EPs go in and register, and EPs will still have to designate a third party to be able to attest on their behalf, but this will greatly reduce the burden for attestation for EPs and for larger practices. Obviously, that's not available yet. It will be available in 2014, and we'll have more information on that as we get closer to that date. Next slide, slide 14. So we have listed here and over the next few slides all of the core and menu objectives for both eligible professionals and for eligible hospitals. I'm not going to go through each and every one of these. I'm going to call out a couple of things. In general, you will notice several things, and nothing that I think is going to be a real surprise for those of you who were familiar with what we had proposed in the Stage 2 NPRM. By and large, what we have adopted in the Stage 2 final is what we proposed, with a couple of notable exceptions. We did cover in the NPRM that we were essentially taking the menu items from Stage 1 and moving them into core with a couple of exceptions. And then we were introducing most of the new objectives as menu items for eligible professionals and eligible hospitals, again with a couple of exceptions that I will point out. We do, at this point in time, it's probably a good opportunity for me to point out that if you visit our website, the www.cms.gov/EHR Incentive Programs website, there is now a new Stage 2 tab that you can visit, and we have some tip sheets that are available for people on Stage 2. Obviously, we're going to develop some specification sheets like we had done for Stage 1 for each of these objectives and measures that will cover them in a little bit more detail. But until then, we do have an overview of Stage 2 meaningful use. We do have separate tables for both EPs and eligible hospitals that demonstrate the changes from Stage 1 objectives to Stage 2. We also have some tip sheets on how clinical quality measure reporting will work beginning in 2014, and also some tip sheets, again, for both EPs and hospitals on how payment adjustments and hardship exceptions work. So I encourage everybody to go to that website and download that information for a little bit more detail if I go by these too fast. What we have done in here is we have bolded that the changes that are specifically from Stage 1, and you'll see that for the most part, the objectives that were carried over from Stage 1 had a concomitant rise in threshold. So e-prescribing moved up to more than 50%. The recording of demographics, vital signs, and smoking status, which were at more than 50%, moved to more than 80%. We moved clinical decision support intervention up to 5 clinical decision support interventions instead of 1. And as I mentioned earlier, we combined some of these objectives, and here you see the drug-drug and drug allergy interaction alerts. Next slide. One of the things that has changed slightly from the NPRM was, and as far as I've mentioned this in his opening remarks, was the summary of care and transitions of care. Obviously, we have moved to providing a summary of care for more than 50% of those transition of care referrals, and we have adopted the that 10% have to be sent electronically. That's electronic exchange. We had proposed an idea and sought comments on the idea of making those 10% that were sent electronically be sent to vendors or somebody who was using a different vendor or a different EHR technology. Obviously, there were some issues with tracking it, but we do remain dedicated to the idea of health information exchange without borders across different, not only areas of care, but also across different technologies. And that is why we have this third measure that we have introduced here in the final, that at least one of the electronically exchanged summaries of care have to be sent to a recipient with a different EHR vendor. We think that the vast majority of people, just through their normal course of practice and exchanging summary of care after transitions of care, are going to be able to meet that. But for folks who may work in an area that has a very high concentration of one particular vendor, or who may work in an area where they may not have a lot of penetration with people with EHRs at this point in time, we are providing the second part of this measure that they could successfully test with what will be essentially a CMS test EHR that you can successfully electronically exchange with. And it does have to be successful. It is not, as we had in Stage 1, the exchange of key clinical information, which was just a test. This does have to be a successful instance. You'll see number 13, secure messaging. This is one of the new objectives that was introduced into the core for eligible professionals. The requirement here is that more than 5% of patients send secure messages to their EP. We did talk a little bit about some of these objectives, which would require patient action. This is a change from stage 1 to stage 2. In stage 1, there was really nothing that a patient could or couldn't do that was going to affect whether an EP was able to meet meaningful use, but there are several objectives in stage 2 that would allow, that affect whether an EP is able to meet meaningful use because it requires specifically some patient action. We truly believe that secure messaging and providing, the other instance here is providing patients online access to their health information, to view online, download, transmit their health information. We believe that EPs and hospitals are in a unique position to encourage their patients to actually use this. We did receive a lot of comments from people about this, and that's part of why we lowered the thresholds for both of these patient actions that are required. We moved from a more than 10% measure to a more than 5% measure, and we did introduce some exclusions based on broadband availability, because that was a concern that came up again from commenters. So we believe that between those, that very low measure of 5% and the broadband exclusion, that all providers should be able to meet that. Next slide, 16. These are the menu objectives for EPs. We have 6 menu objectives. For the most part, these are all new except for number 3. Number 3 is syndromic surveillance. It was one of the public health reporting measures from which people could select in the menu in stage 1. We did leave this in the menu for EPs because right now there aren't a great number of syndromic surveillance databases to which EPs can submit. So we did leave that in the menu. But you'll see imaging results, family history, and progress notes are also menu objectives for eligible hospitals. We did introduce some things specifically for specialists, such as transmitting information to a cancer case registry or to a specialty registry in number 4 and 5. Number 6 is the objective that we added back in. We had initially not adopted this, or not proposed this rather, in the stage 2 NPRM. The Health IT Policy Committee had recommended including this. We felt that it was pretty ubiquitous in use already. So we did not propose it, but we did solicit comments on it. And the comments came back overwhelmingly with people supporting the idea of having the measure of electronic progress notes available within the EHR. So that is now included for both EPs and hospitals. Next slide. These are the hospital core objectives. Again, a lot of crossover. You will see, I'm just going to draw attention to a couple of new things. One is here, number 8, is the EMAR. It's the medication administration. It's electronic tracking of medication that we have implemented. It is for more than 10% of medication orders throughout the hospital. It is a fairly low measure, and we did get some comments from people who were concerned about very small hospitals, so there is an exclusion that is available for very small hospitals. I would encourage people to go and take a look at that. But this is one of the new objectives that we did put into the core because we think that the benefit to patient safety from medication tracking could be enormous. Next slide. And then again, you'll see the same measure here in number 12 with summary of care of the third measure of at least one of these electronically are sent successfully to somebody else with a different EHR or a different or successfully testing with the CMS EHR. We also, you'll see number 9 is the patient access objective. This is the providing online access to health information, and the second measure is more than 5% of patients actually accessing that information. Again, going back to the encouraging patients to actually take active part in their health care by accessing their own information. Next slide. These are the menu objectives for hospitals. Hospitals have to report on 3 out of 6. Progress notes, number 1 there, as you see. We discussed that earlier. Number 5 is the only menu item that was actually retained from the stage 1 menu and left here in the stage 2 menu is advanced directives. And the reasoning for that really is that at this point in time, we've got pretty conflicting results or reports about what would be legally substantial in various states. And until we get some agreement about what that is, we didn't feel that we could advanced directives. We also have introduced number 6. We discussed this but did not necessarily propose it, but it is for hospitals to provide structured electronic lab results to EPs for more than 20% of lab results. Again, a menu objective that hospitals can select 3 out of 6. Next slide. So we talked about this, patient engagement being one of the major emphases for stage 2, and that's where we have the emphasis on the more than 5% of patients having to send a secure message to their EP, more than 5% of patients actually accessing the health information that both EPs and hospitals make available online. We do provide exclusions based on broadband availability in the provider's particular county. It is key to the FCC's broadband map. Please take a look at the rule. There's going to be a little bit additional information that will come out about this, but we did hear that fairly regularly from people. They concerned that in low broadband areas there would not be enough people to be able to access. Next slide. And then Farzad mentioned one of the things that we focus on here is electronic information exchange in stage 2. Obviously, the standards that were put in place on the O&C side for these particular exchanges are a giant leap forward, but another leap forward here in meaningful use is the requirement of not only providing those transition or summary of cares for transitions of care, but the 10% electronic transmittal requirements and the requirement to send at least one of those summary of care documents to a different vendor or to the CMS test EHR. Again, the emphasis on breaking down the walls to be able to exchange information not only across different areas of practice, but across different networks. Next slide. So these are some of the changes to stage 1 that were proposed, that were finalized. Most of these were proposed, and it should be familiar to folks that were familiar with the stage 2 NPRM. You'll see on the bottom of each of these there is a designation of when this becomes available. Many of them are available as an option in 2013 because we know that there are some folks who may be able to implement 2014 technology ahead of time. Many of them will be required beginning in 2014 when the new technology is available, and we'll have all of these built-in capabilities. So everybody knows, there is an outline of the stage 1 changes as a tip sheet on our website under the stage 2 tab. Again, that's www.cms.gov/EHR incentive programs. And in case I go too fast on these, there's a little bit more of a breakdown on our website. Tip sheet. So one of the things that we introduced for the computerized provider order entry was an optional denominator for CPOE. A lot of people had some issues with the current denominator, unique patient with at least one medication in their medication list. It was difficult for providers who shared an EHR but perhaps did not do a great deal of computerized order entry or order entry at all, or orders at all. To actually meet this. Some folks had some issues with calculation because they weren't sure what medications went in, whether it was only medications that the EP ordered, it isn't, whether it is only medications that are ordered during the EHR reporting period, it isn't. But again, there was a great deal of confusion about it, so we have introduced a new stage 1 option that the denominator can be limited strictly to the number of orders, medication orders during the EHR reporting period. So getting rid of unique patients with at least one medication and just restricting it to number of orders. The percentage threshold would be the same. It's just the denominator that would change. And again, this is an option that's available in 2013 and beyond for stage 1, but it will not be required for stage 1. Next slide. This is slide 23. This is vital signs. We did hear, well, we heard a number of things. One of them was regarding age limits. We did change the age limit from age 2 to age 3. This is to be in line with the American Academy of Pediatrics guideline currently on vital signs. There is an age 3 for blood pressure, no age limit for height, weight. We did hear a lot about the exclusion that is available for vital signs currently in stage 1. That exclusion is that all 3 of the elements of height, weight, and blood pressure are not relevant to a scope of practice. Obviously, there are a number of specialties that came back to us and said they might record one but not the others, or vice versa, and asked for us to split the exclusion. We did propose that and are adopting this as an option beginning in 2013. It will be required starting in 2014. But obviously, there's still an exclusion for all 3 elements, but there is also an exclusion if just blood pressure is not relevant to your scope of practice, and there is an exclusion to recording height and weight if just height and weight are not relevant to your scope of practice. Next slide, slide 24. This is, we mentioned earlier, the test of electronic transmission of key clinical information. This presented a lot of difficulty, and as we moved to stage 2, where we're actually emphasizing health information exchange within regular course of practice through the summary of care transition or summary of care record after transitions of care, we're actually going to remove this requirement, remove this objective completely, effective in 2013. So the test of electronic transmission of key clinical information will be no longer required beginning in 2013. Next slide. We had several objectives for both EPs and hospitals that center around providing patients either an electronic copy of their health information upon request or providing electronic access to health information. EPs had this as a menu objective where they can provide electronic access to health information online to patients. Those are currently in stage 1, but when we move into 2014, rather than maintaining these separate objectives and having separate measures for them, we are transitioning towards the new stage 2 objective, which allows providers or requires providers to provide information online for patients to be able to view, download, or transmit. So beginning in 2014, when to coincide with those new certification standards criteria, there is going to be we're going to get rid of the previous objectives on copy of health information and electronic access, and they'll be replaced with this new objective to provide patients that ability to view online, download, and transmit their health information. It is important to make a distinction that in stage 2, there are 2 measures to that objective. The one is that 50 or more than 50% of patients have access to that information. The second is that more than 5% of patients actually access the information. That second measure of more than 5% of patients being able to access the information is not a requirement for stage 1. That is a requirement specifically for stage 2. For stage 1, the only requirement is to provide that information online, to view online, download, and transmit. Next slide, 26. And finally, the last change that we have here to stage 1 is some addition of language to the public health objectives, immunizations, reportable lab, and syndromic surveillance. We are adding the language to the measure except where prohibited to all of these objectives. It came to our attention that there are some people who were sort of caught in a catch-22 where they were required by meaningful use to report on these, and yet for whatever reason, either a local or state guideline or law prohibited them from actually reporting on those results. They were sort of caught in a situation where they couldn't meet the measure. So we're adding this for clarity purposes. It doesn't really change the stage 1 measure for those objectives. It just prevents providers who might be in that loophole or who might be in that catch-22 a loophole to get them. Clinical quality measures, slide 27. As we move forward, clinical quality measures, as I mentioned, will change for all providers beginning in 2014. This is regardless of your stage. Everybody will report the same clinical quality measures beginning in 2014, regardless of whether you are stage 1 or stage 2. There are also some new methods of submission, and I'll go very quickly through all of those. Slide 28. One of the things that we did do is we removed the reporting of clinical quality measures as a separate objective of the EHR incentive programs. It seemed to be an unnecessary step with people just indicating yes and then having to report on the clinical quality measures. You are still, however, required to report on clinical quality measures as part of meaningful use in order to receive an EHR incentive payment. So still required. The other thing is that in 2014 and beyond, we're attempting to streamline the reporting between various CMS programs in order to reduce provider burden. Some of that is happening through alignment of the measures that are reported between the two programs or between the various programs, and some of it is through alignment of the reporting methods. So hopefully we're getting to a point where you will report on the same measure sets through the same method, and it will count for a variety of programs. Next slide, slide 29. So this is just the programs that we were really trying to align across, EHR incentive program, the hospital inpatient quality reporting program for hospitals, the physician quality reporting system for EPs, CHIPRA on the Medicaid side, and then there are a number of EPs who are going to be participating in the ACOs, and there are particular quality measurements for ACOs that are required. If you report on those, you'll be deemed for having met the EHR side. So attempting to align across those different programs. Next slide. Again, focusing on choosing those same measurement sets. We did coordinate some of the stakeholder involvement efforts from different folks in developing some of those quality measures, and will as we move forward. And as I said, trying to minimize multiple submission, getting to the point where we can have hopefully one day one single system, but at least at this point in time, being able to deem so that multiple submissions aren't necessary in as much as that's possible. Next slide. Obviously, we're trying to reduce provider burden here, but still maintain supporting all of those quality measurement programs, because ultimately the idea with this quality measure is to deliver that higher quality, better health outcomes, and reducing costs across the healthcare system. Next slide, 32. One of the things that you will see in 2014 CQMs is an alignment with the Health and Human Services priorities. One of the requirements, in addition to the number of CQMs that will have to be reported, is that the clinical quality measures will have to be selected from at least 3 of the 6 national quality strategy domains. Those are listed below, but they dovetail pretty neatly with a lot of the objectives of the EHR incentive program. Obviously, patient and family engagement, patient safety, care coordination, population and public health, efficient use of resources, and clinical effectiveness. We will post, the CQMs are not, the finalized CQMs are not yet available, but they will be posted on our website within the coming months. And we will also indicate at that time which clinical quality measures belong to which domains. But you're going to have to select from at least 3 of those 6 domains. At least 3 of those 6 domains have to be represented in your selections for both EPs and hospitals. Next slide, 33. And there you see. They will be posted on our website. There's our website. We will also post a recommended core set of clinical quality measures for EPs that focus on high priority health conditions, blood pressure maintenance, things like that. So there will be a set for both adult and pediatric core. And again, we'll have that on the website relatively soon. Next slide, 34. One of the things that we also proposed here and have finalized is that beginning in 2014, all Medicare-eligible providers, this is both EPs and hospitals, in their second year and beyond of meaningful use, are going to have to electronically report their clinical quality measure data to CMS. There are several ways that they can do that. We'll go over that in a second. Medicaid providers would electronically report their CQM data to their state if that's available. Obviously, if they're in their first year of meaningful use, they're still going to attest to their clinical quality measure data. But beginning in their second year, they're going to actually electronically. Next slide. So this is an overview of where things will change for clinical quality measures in 2014 and beyond. Currently, EPs report on a core or alternate core set of 3 and 3 menu items. Hospitals report on a set of 15 clinical quality measures. In 2014, EPs will report on 9 out of 64 measures, and hospitals will report on 16 out of 29. Next slide. This table, although it seems a little complicated, I'm going to be able to hopefully compress this for you very quickly. It is essentially how the reporting will happen for eligible professionals in 2014 and beyond. Again, if you're an EP in your first year, you're going to attest to your CQM data. You'll enter it the way that it is currently entered now on the web attestation. If you're beyond your first year of demonstrating, you will have an option of either submitting through the PQRS EHR reporting option, the physician quality reporting system, or you will have an option to submit aggregate level data through a method that CMS is going to indicate in the future. Obviously, it's not available at this point in time, but it will be electronic reporting through a separate aggregate option. There's also going to be a group reporting option for EPs for clinical quality measures. This is limited to clinical quality measures. Again, for EPs beyond their first year of demonstrating meaningful use. Obviously, there's still the PQRS option. There's a group reporting option within PQRS that EPs can report through and satisfactorily have met the requirements for the EHR incentive program. There is also one for ACOs. So if you are reporting through the Medicare Shared Saving Programs, you'll be deemed to have met EHRs. Next slide. Hospitals will have something similar, obviously in their first year attestation, but in their second year there will be a something similar to the Medicare EHR Incentive Program electronic reporting pilot that exists now to report through. There will also be another aggregate level option through which they can report. Again, we'll have more information in the future. That system isn't available yet, but there will be two options to electronically submit. Next slide. I'm going to pick up the pace on the last of these, but I do want to point out that there is a 2014 clinical quality measure tip sheet on our website that has a lot of these same tables that you can take a look at. It'll give you some more information about the reporting electronically and otherwise, and how clinical quality measure reporting will work in general. So I encourage people to go and take a look at this. This essentially talks about the different reporting periods. There really is not a change from stage 1 to stage 2. You would, in your first year, do 90 consecutive days of reporting. You would then do a full year of reporting, and this just outlines when the actual submission period for that would be. Next slide. In 2014, as we said, there is a 3-month reporting period option. You could either report on an entire year for clinical quality measures, or you could report on the quarter, but either way, you won't be able to submit until the end of the calendar year. It's just the way that the clinical quality measure reporting systems work, and this outlines what those quarters actually are. Next slide. As I said, there's going to be a core set of clinical quality measures, both pediatric and adult, that are posted for EPs. We focus on conditions that contribute to morbidity and mortality, things that represent particular national health priorities, conditions common to certain health disparities. Next slide. Those things that are really driving healthcare costs. Again, all of this is to focus on those 6 national quality strategy priorities that we talked about earlier. Next slide. So all of this, of course, brings up the question of what CQM reporting will be in 2013. CQMs basically remain the same through 2013. There will be some update of the electronic specs for the CQMs. There will be 2 reporting methods, as there are now, available for reporting those stage 1 measures, attestation and e-reporting pilots. There's a PQRS pilot and also an e-reporting pilot for hospitals. And of course, Medicaid providers will continue to submit their CQMs through state-based attestation. Next slide. I'm going to cover payment adjustments and hardship exceptions, which has a lot of tables that I don't necessarily have to walk you through each one. They're more for your reference. They're also on tip sheets on our website that you can take a look at. If we go to the next slide, the one thing that we want to say here that is very important to keep in mind, obviously payment adjustments were mandated by the HITECH Act, and to avoid payment adjustments, it was specifically stipulated that you had to be a meaningful user. So if you are adopt, implement, upgrade in the period that we indicate here, that doesn't count as meaningful use. So if you receive an adopt, implement, upgrade payment from Medicaid, that's not going to qualify you as a meaningful user. And if you are still have Medicare claims, then they would be subject to a payment adjustment. You'll see over the next few slides, we detail out what the different payment adjustments would be. Number 45 talks about what the different payment adjustments would be depending on the number of EPs or meaningful user. This was provided for in the HITECH Act. If you go to the next slide, slide 46, it essentially begins the process of explaining what we had already explained in the NPRM, or what we had already proposed in the NPRM. We are essentially doing a prospective period of look back for the meaningful use reporting period, because we have to begin collecting or applying the payment adjustment in 2015. So essentially, if you demonstrated in 2011 or 12, we're going to look back to the last full year EHR reporting period that you have, and that period is going to be back in 2013, because people have they have 2 months after the close of the year to report, so we wouldn't have your 2014 by then. We often get the question of whether you just have to demonstrate once or whether you have to demonstrate continuously. And as this chart illustrates, you're going to have to demonstrate every year to avoid payment adjustment in the subsequent year. So in 2015, we look back to 2013 to see if you're a meaningful user. In 2016, we look back to 2014, and so on. Next slide. If you're a 90-day reporter or a first-year participant in 2013, we're just going to look for your 90-day period in 2013, and then we'll look for a full year in subsequent year. Next slide, 48. If you are a first-time meaningful user in 2014, we will look at the 90 days in 2014, but we do need time to process all of those attestations. So we are putting a limit on it. You will have to have your 90-day attestation into us no later than October 1st, 2014, which means the last day that you can have begin a 90-day reporting period for 2014 would be July 1st. If we go to the next slide, the question comes up if you are eligible for both programs as an EP or a hospital. Would participating in one or the other qualify you? And yes, we do share data across the program, so if you do qualify under Medicaid, you would avoid the Medicare payment adjustment as long as you qualify as a meaningful user. It can't be for adopt, implement, upgrade. Next slide. Very quickly, the subsection D hospitals work very similarly as far as the look-back period. This slide on 50 just outlines what the actual percentage decrease would be to IPPS that is applied. Again, this is in the HITECH Act. But if we go to 51, you will see that the timeline that we look at is very similar to what we look at EPs. We just work on fiscal years for hospitals rather than calendar years for EPs. So your full year, we look back for 2013, or a 90-day reporting period for the first time in 2013, beginning in 2015. You do have to continue demonstrating every year to avoid the penalty. If you go to 52, there's the same portion for a 90-day period for a first-time meaningful user in 2014. The last day for hospitals to do that, because we need time to process, will be July 1st of 2014, again on the fiscal year, which means your last day to begin that 90-day reporting period for hospitals will be April 1st of 2014. Next slide. This outlines what the applicable payment adjustment against reasonable cost reimbursement for critical access hospitals would be. Again, this is within the HITECH Act. If we go to slide 54, the next slide, you'll see that it works slightly differently for critical access hospitals because of the way that cost reports are filed. So we basically look within the same year for that payment year, because payment would be applied to reasonable cost for cost reports that are filed after the payment year. So we can apply it, we can look at the same year. And that's essentially what these different tables outline for critical access hospitals. Slide 55 outlines the hardship exceptions that we have finalized. They are pretty much what we had proposed in the NPRM, including number 4 and 5. We had specifically sought comment for some specialty-based or scope of practice-based exceptions. So there are exceptions for lack of infrastructure infrastructure. There are exceptions for newly practicing EPs so they would not immediately be subject to the penalties. There are exceptions for unforeseen circumstances, and then EPs who either lack face-to-face and have a lack of follow-up need with patients, or EPs who practice at multiple locations and must demonstrate that they lack control over whether they have certified EHR technology in those locations. And we did specifically call out anesthesiology, radiology, and pathology as specialties that we think would automatically fall within 4 and 5. Which is what slide 56 says. We are going to have an application process for hardship exceptions. We'll have more information about that when that is available, but there are deadlines to applying, and that is July 1st of the year preceding the payment adjustment year in order to qualify for that hardship exception. 57, slide 57 next outlines the eligible hospital and critical access hospital hardship exceptions, which are similar to the first 3 that you'll see for eligible professionals, infrastructure, new hospitals, and unforeseen circumstances. And slide 58 just lets you know that we will be going through an application process for those hardship exceptions and what the deadlines will be. Next slide, slide 59, we do have some changes to Medicaid patient volume calculation, and I won't go through all of these. These are here for your reference to demonstrate what it is, but slide 60 gives you the brief overview. Essentially, we added in some flexibility to allow Medicaid expansion encounters and those with zero pay claims to be included in patient encounters, some flexibility in the look-back period for overall patient volume calculation, which should essentially make it a little bit easier for some folks who are on the bubble to be able to qualify for the Medicaid program as eligible professionals. And that's essentially what the following slides in 62, 63, and 64 go through. The different patient volume calculations, and again, included for your information as a brief overview of what it looks like. On slide 65, one of the things that we did here is we did make approximately 12 children's hospitals that have been inadvertently prevented from participating in the program because of their CMS certification numbers, or actually lack of CMS certification numbers. They are going to be able to participate in that program. And then finally, in slide 66, there is a change in the hospital incentive calculation for determining discharge-related amounts. This gives a quick overview, but hospitals that begin participating in fiscal year 2013 or later can use discharge data from the most recent continuous 12-month period, and hospitals that begin participating before 2013 use discharge data from the hospital fiscal year that ends during the fiscal year prior to that fiscal year that the services are in the payment year. There's a little bit more information about that in some FAQs, which are linked from our website. If we go to the slide 67 and our last slide, that is the web page for Stage 2. Again, you'll find links to the Federal Register for both the CMS and ONC rules, tip sheets on the overview, clinical quality measures, payment adjustments, changes from Stage 1, and also some links to those patient volume FAQs for Medicaid. And I'm going to apologize to my colleague, Steve Posnack from ONC, for going a little late on this one, but there was an awful lot of material to cover. I hope that that Cliff Notes version of Stage 2 was useful for folks, and Steve is going to talk a little bit about 2014 certifications.
All right, thanks a lot, Rob. I'm going to also probably just have say next slide, if that works for the NeHC folks.
Yeah, no problem, Rob. You're a little soft, so just be sure you get close to your phone. Or I'm sorry, Steve.
How's that?
That's good. Thank you.
All right. Yes, apologize. I'm on a cell phone as well. So I just wanted to briefly say that I will follow the mantra that if I can't cover what I need to cover in 12 minutes, then it wasn't worth saying today. So I am from ONC, Director of our Federal Policy Division, going to cover our 2014 edition Standards and Certification Criteria Final Rule. The probably top 5 themes that I'd like you to come away from the final rule, that I feel you will take away from the final rule as you read through the preamble, is that we focused on enhancing standards-based exchange, promoting EHR technology safety and security, enabling greater patient engagement, introducing transparency requirements as well as part of the certification process, and then also looking at areas where we could introduce flexibility and reduce regulatory burden. Next slide, please. So I wanted to cover this briefly because I know from 2 years' worth of experience that we have encountered some confusion about our rules, and the rules, the certification criteria and standards final rule, as well as the meaningful use rules, are largely complementary and supportive in nature, but they have different scopes. And so I wanted to make sure that folks kind of grounded themselves as you probably reread the rules again this weekend, that our rule, ONC's rule, is technical in nature, and it specifies the capabilities that EHR technology must include and how the EHR technology needs to perform in order to get certified. It does not specify how EHR technology needs to be used. And so that's really where meaningful use, the scope of the rule that Rob just covered, focuses on the behavioral changes, how you use the EHR technology once it's certified. And so, you know, if you interpret ONC's rule through the lens of how EHR technology should or could be used, there's a high likelihood that you will misinterpret ONC's regulatory requirements. As a kind of quick point in case, for the view, download, and transmit to a third-party certification criterion, we require for certification for EHR technology that the capability to use the applicability statement for secure health transport standard, EHR technology needs to include that capability. However, when you go over to the meaningful use side, CMS permits additional flexibility in demonstrating meaningful use. You're not limited to using that transport standard that the certified EHR technology includes. Similarly, for patient education materials, we require that the HL7 info bucket standard, EHR technology be able to support that, as well as another mechanism for education materials. And in meaningful use, you can use either one of those options as part of getting your actions to count in the numerator. And so if you look at our rule, ONC's rule solely and interpret it through a use perspective, then you may interpret the rule incorrectly. Next slide, please. So I'm going to cover, if you saw my prior slides way back in March, I'm going to do a little bit of compare and contrast pretty quickly. So on the left side here, we have our MPRM. On the right side, we have our final rule. These are the categories in the paragraph level that we've broken down into the 2014 edition, which, again, it was not a coincidence that we picked a section in the Code of Federal Regulations that also had a 14 in it to make it easy for people to remember. As folks read through the preamble, you'll see that we consolidated a couple certification criteria. We also removed a few certification criteria that we felt no longer specified the policy objectives that we absolutely needed to do so for certification, and designated others optional as well in response to comments. Next slide. So these are tables that I used before. I'm going to breeze through these pretty quickly. List of categories of new certification criteria. You'll see a trend of having red strikeout, green added in things. We've added in 2 certification criteria. I'm not going to cover in detail today. As a quick pause and a plug, Rob and I are going to be doing, or Travis, my other partner in crime from the CMS side, will be doing these presentations again next week. We'll also be at the HIT Policy Committee in September and the HIT Standards Committee in September. So there will be plenty of opportunities for us to both improve our presentations and to get into more detail. Next slide, please. In the revised certification criteria, there are a few that you'll see when I get to the slide that follows here that moved from unchanged categorically to revised. And in some cases, we made minor changes, but in those cases, we felt that per our interpretations that we had issued previously, they fell into the revised certification criteria category. Next slide. So the ones that have the orange strikeout here were revised from their kind of proposed status of being unchanged in response to public comments, and those got moved into the revised table on the previous slide. Yeah, the 2 that are red line strikeout, we indicated for reasons expressed in the preamble that we didn't believe that they were necessary to require for certification anymore. So the ones that remain in the black text are what we call would be eligible for gap certification, which means that the EHR technology developers will be able to use previously issued test results to continue counting towards their certification to the 2014 edition. Next slide, please. Okay, so on the left-hand side, I'm going to get to probably one of the crown jewel elements here of the presentation and ONC's rule in general. One of the things that contributed to a lot of tension and angst after our first final rule came out, and that had to do with the definition of certified EHR technology, capital C, EHR, capital T technology as the term of art as it's defined in our regulatory text. The July 2010 final rule policy was really a static definition that was driven by the quantity of certification criteria, the amount of certification criteria that we had adopted in our final rule. Now that option is still available and is effective through 2013, but we've also included other flexibilities for providers to adopt in meeting the definition of certified EHR technology. This final rule, as we had proposed and have finalized in pretty consistent manner, adopt a dynamic definition of the definition of certified EHR technology, which is going to be driven by meaningful use. And so per public comments that we evaluated, this new dynamic definition that focuses on the quantity of EHR technology that you need to meet the stage of meaningful use that you seek to meet will be effective as soon as the final rule is effective, and also once EHR technology certified to the 2014 edition certification criteria becomes available. So there will be a little bit of time lag, but I think we've seen that during the 2013 EHR reporting period for meaningful use that providers may be able to take advantage of this additional flexibility. Next slide. Okay, so with the revised certified EHR technology definition, the most important point to keep in mind is quantity, quantity, quantity. It is all about the quantity of EHR technology certified to the 2014 edition certification criteria to the meaningful use stage that as a provider you would seek to meet. And the one thing to keep in mind that I also expressed with during our NPRM is that in defining certified EHR technology, it really speaks to two different audiences. It speaks to providers so that they know the 2014 edition EHR technology that they would need in order to demonstrate meaningful use. And then it also speaks to EHR technology developers so that they have an indication and a roadmap in terms of the capabilities for which certification would be required that they need to design in, and also seek certification based on their kind of customers and market and the types of providers that they service to. And so in this case, you know, we really took a hard look at the rule and tried to make this definition designed in such a way to make it possible for EHR technology developers to do what makes sense from a business perspective and from the perspective of the capabilities that their clients would need in order to achieve meaningful use. And so EHR technology developers now going forward have a real opportunity to work with the regulatory framework that we've now finalized to rethink how they're packaging their software from a certification perspective and to offer what I like to call right-size certifications to their customers. Next slide, please. Okay, so this is the bullseye diagram that folks that first saw it at HIMSS will remember. I'm not going to go through this pretty quickly. Again, this is a resource for your reference. We have there's a few other slides in my slide deck here that explain the policy related to the definition of certified EHR technology. We've gone with a lot of imagery and analysis to make folks' lives a whole lot easier. Next slide, please. So one of the core pieces, as you saw at the center of that bullseye, was the base EHR definition. And the one thing to make sure that we saw in public comment that really didn't come across clearly, and that's our bad in terms of explaining it, you know, during the presentations that we were given, is that it's a definition, and it's meant to be used like a checklist on your way toward meeting the definition of the certified EHR technology. And so if you find yourself doing this, please try and stop yourself. It's not a quote-unquote A-based EHR. It's not a singular type of EHR technology that has to have these capabilities. We were not implying that these new types of EHR technologies needed to exist called base EHRs. It's more of a concept that you need to have EHR technology certified these certification criteria. Thank you for advancing me. It'll help me go faster. And so under
Steve, I think we might have lost you. Are you there? I think we lost Steve's line for a moment here. I'm sure he's going to dial back in. But in the meantime, I think I'm just going to roll right to another question, to a question or two. We are running out of time, and fortunately, we have the programs planned again for next week. But so, Rob, if you're still with us, I think I have a relatively easy one for you.
Are you back? Am I back?
Oh, Steve, yes, there you are. Okay, I was just going to roll to a question or two. That's all right. Go ahead.
I apologize. No,
No
during
problem.
the whole webinar, my phone didn't cut out, and of course.
In the last 30 seconds, right? Go ahead.
All right, I will breeze through this pretty quickly. Scenarios 1 through 6 here on the slides show that regardless of stage, regardless of the type of provider that you are, everyone will still need to have something that meets the base EHR definition from a quantity of EHR technology perspective, also trying to show the variability in different vendors and how the certifications, either complete EHR certification or EHR module certification plays out. And you can see as you step up through meaningful use stage 1, in terms of the quantity of EHR technology that you would need versus stage 2, there is variability. So someone meeting stage 1 wouldn't necessarily need to have EHR technology certified to the entire suite of certification criteria that we include in our final rule. Next slide, please. So there are now 3 ways to meet the certified EHR technology definition. If you have a complete EHR as a vendor, your vendor gets that certified. This pretty much gives you complete assurance, ultimate assurance. There are the cancer registry reporting certification criteria that were designated optional. So if you want to do that, then you need to make sure you have EHR technology certified to those. And then the one point that I would call out here is that given the new dynamic definition of certified EHR technology, and if you compare it to the prior slide, there is now the potential for a single EHR module that has just those capabilities that a potential group of healthcare providers would need to meet in order to achieve meaningful use. And so I like to call these mega modules, but this gets to the kind of right size certification and those capabilities that would be part of someone's overall EHR technology that for which certification is required to meet the definition of certified EHR technology. I'm going to breeze through these pretty quickly because I know the next bunch are for reference. So next slide. All right. The green text just shows from a prior table that we've used about the additional flexibility that we have included in the final rule about using a 2014 edition EHR technology to meet the certified EHR technology definition, as well as in this limited quantity perspective. Next slide, please. This is just for your reference. Next slide, please. So again, this is briefly touch on this. This is available on our website. These are infographics to explain how you meet the definition of certified EHR technology. And there are ones for either stage as well as, next slide please, based on EP and EHs and CAHs, trying to follow the color code here as well. So you can kind of go through these and use these as a checklist. There are other elements to the base EHR definition that I didn't cover with respect to clinical quality measures, but suffice it to say, a lot of this is really aggregated and summarized in these simple slides. Next slide, please. So we also, as the CMS statement as well about don't forgetting about stage 1, don't forget about the changes that we made to our permanent certification program final rule. We tied the sunset of the temporary certification program to the effective date of this final rule. We also are changing the name since we no longer have a temporary and permanent certification program. We've made other efficiency changes to EHR module certification that we believe will make the process faster and make it easier for EHR technology developers to provide those right-size certifications to their clients. Next slide, please. We've also included, mostly as proposed, the application of certain new certification criteria to EHR technology, and so this is included through the certification process that the ONC authorized certification bodies need to ensure that depending on the type of certification sought, these certification criteria are evaluated in addition. 2 other points here that I won't go into too much detail because I think at a minimum the context and the policy here expressed on the slides has to do with price transparency and test result transparency as well. And so these are requirements that ONC ACBs need to follow in issuing certifications. Next slide, please. I'm just going to, the following slides here are just to show the applicability of certain standards to the certification criteria, which are roughly summarized in this purpose column, and then the different types of standards that apply to those certification criteria. You can, next slide, I think there's 3 of them you can kind of tip through. These are for your reference. I'm probably going to go back and make these better at some point when I have a little more time. Keep going. All right, so what's next? Brief timeline. Final rule is issued. Hooray. And there's still a lot of work to be done. As Rob mentioned, the clinical quality measure specifications, which will have a linkage to the testing processes as well. As before, folks remember 2 years ago, we, with our colleagues at CMS and with NIST and through ONC, expect there to be waves of test procedures to be published. Those test procedures will be available like before for a period of public comment. The other point is, I believe our final rule becomes effective on October 4th, and so that would be the final rule effective date for the temporary certification program. So as all these dominoes start to knock into each other and fall into place, that's when you'll start to see more information rolling out, and then as soon as all those dominoes fall down, the 2014 EHR certifications will commence, and then everyone will be off to the races. So that sums it up.
Thank you, Steve. For those of you who can bear with us, this is Kate again for just a few more minutes. We have a lot of questions, and again, we're going to have another couple of programs on these topics next week, but I wanted to just roll through a couple of questions with you guys, Steve and Rob, if that's okay, and we'll keep it just to a few more minutes. So one is, and I think this is for Rob, do you know at this point when the CQM specs will be posted on the CMS website?
At this point in time, I don't. I think that they are shooting for beginning of October, but I couldn't tell you to be absolutely certain.
Okay. And let's see. So another one, I think this is probably for you, Rob, if you can answer. If a patient responds to an email appointment reminder that he or she will or will not attend, that one's not clear, sorry. I am going to have to skip that one. Let's see. Oh, this one's for Steve. So can you address vendor certification and when CCHIT and InfoGuard will have the scripts? Do vendors need to recertify for stage 1 based on the changes to some of the criteria?
Any product today that's been certified for the 2011 edition is good to go as long as providers are using them during the EHR reporting period, for which that EHR technology would be continue to be valid. But as we approach the 2014 EHR reporting period, that's where EHR technology developers will need to go through the process of getting those capabilities for which there are new 2014 edition certification criteria retested and recertified through the ONC HIT certification program. And the test procedures, as I mentioned at my last slide, these things that will be rolling out in the coming weeks, and then available for public comment. And there'll be this iterative process whereby they'll be finalized, as well as the clinical quality measures, e-specifications as well, that I know that our EHR technology developer friends are anxiously awaiting as well.
Very good. And Rob, I think this is for you. Could you repeat the last date to attest in 2014 for hospitals to avoid penalties? Was it July 1st or April 30th?
It's July. It's 90 days or 3 months before the end of the fiscal year, which puts it at July 1st. April ends up being the date, the last date that you can begin a 90-day reporting period. And again, please take a look at our website. If you get that payment adjustment tip sheet for hospitals, it outlines both of those dates for you.
And this is an easy one for you, Rob. So can a provider participate in both programs at the same time, the Medicaid and Medicare programs?
No, nothing has changed about that. Hospitals are eligible to receive payments from both Medicare and Medicaid, but eligible professionals have to choose between which program they want. Obviously, if you can qualify for Medicaid, and there are now some more flexible patient volume calculations that are going to be available in 2013, you want to try and do that because the incentive payments are higher through Medicaid. You are going to have to select one or the other.
And again, for you, is the 3-month EHR reporting period or a testing period in fiscal year 2014 sufficient to avoid payment adjustment in fiscal year 2016?
I don't know if that was you, John Travis, who sent that or not, because also sent it to me by email. That's a good question. As some people may notice that the payment adjustments point to a previous year, and we do point to looking for a full year in 2014. Obviously, we put that together without thinking a whole lot about the extra 3-month flexibility or the 3-month reporting period flexibility that we have put in. What we're really looking for is that at that point, you were a meaningful user during that period. And if you look at those charts, that's really what all of those charts are pointing to, is we're looking back to see if you were a meaningful user prior to that actual period. So in 2015, we're going to look to see if you've got a full year in 2013. If you've got 90 days in 2013, you've got 90 days or that 3-month period within 2014.
And this one's for Steve, and you probably hit this real quick, but so when will vendor certification begin?
It's hard for me to give a definitive timeline because the test procedures have to be published for all the new certification criteria, and those have are in the process of being finalized right now, and then they'll be subject to the period of public comment. So I think there is a window variability in terms of when that would start, but it's in everyone's interest to have it start as soon as possible, and that's what we're shooting for, because I think just like you saw with the final rule, there's intense commitment from everyone in the department to get these rules out as soon as possible, recognizing the timing concerns that commenters had expressed, and I think the same is going to be true with the test procedures and the other elements that still need to fall in place.
Great, and thanks you guys for bearing with us a few minutes over time here to take a few questions. Steve, this one's for you too, I think. So as a vendor, we are just certified for stage 1. Do we have to get recertified in December, by December 31st of 2012, or can we carry our current certification into 2013?
Right, that's correct. And we had addressed this in the preamble of the sorry, I was saying correct in terms of I understood the question. We had addressed this in the preamble of our rule. Previously, our rule required that the EHR technology developers say that their EHR technology was 2011-2012 compliant. That certification is extended in terms of its validity through 2013, at which point, starting in the 2014 EHR reporting period, that's when EHR technology certified to the 2014 edition would be necessary to meet the Certified EHR Technology definition. So if your product is certified now, its certification is valid through the 2013 EHR reporting period.
Thank you. This one is for Rob. When talking about the e-prescribing and PQRS getting streamlined, are ERX and PQRS going away, or are they getting included in the ARA CQM measures? Can you respond to that one?
Well, I think we've actually got some information on our website right now that talk about how how e-prescribing and EHR incentive program overlap. The adjustments for e-prescribing actually end up being absorbed in some way into EHR incentive, because if you do e-prescribing through the Meaningful Use program, you're going to meet those e-prescribing requirements. The attempt here is to align PQRS measure reporting sets with the EHR incentive program reporting sets. And then there's the possibility then to report through PQRS, either through that individual pilot option or through the group reporting option. And that would allow providers to meet both the PQRS requirement and the EHR incentive program requirements.
And I think this is for you too, Rob. So is there a definition or an explanation of syndromic surveillance that you can direct us to, perhaps on your website or someplace?
Like I can direct you to the Stage 2 final rule, which we discuss what syndromic surveillance is. It's a comment that people had, and it is something we address next.
Oh, very good. All right, I am going to actually just bring us to a close now, and I want to first of all really thank Rob and Steve. You covered an incredible amount of information very efficiently, and obviously there's a high degree of interest in this information. So thank you for those very informative presentations, a little bit of Q&A, and thanks everyone for being with us today. We are going to just pop up a quick survey for you to that's going to pop up as you exit the webinar, so please do just take a moment and complete that. And we will be offering these programs again next week on Tuesday and Thursday. So you will see additional information, and at that point, hopefully we'll have a little bit more time for Q&A since many people do have questions. But we're so grateful, Rob and Steve, for covering this topic, literally in less than 24 hours since the rules became final. So I think everyone's very appreciative. So thanks everyone again for joining us, and I hope you all have a wonderful weekend.